Alright, guys. Good evening, good evening, good evening. Arjun Kumar, renal injuries and bladder injuries we'll be talking about when we talk about in our urology chapter. ठीक है जब हम urology discuss करेंगे then we'll talk about renal injuries as well as bladder injuries there. ठीक है so trauma में that is why we didn't cover renal and the bladder injuries. That will be covered when we do our urology वाला part. ठीक है now the last week when we left the chapter of the breast where we were talking about the clinical findings, so we started with the basic objective of called as the triple assessment. The triple assessment में ऐसे clinical approach to the breast lump. In the clinical approach to the breast lump, the first step that you do is going to be a clinical evaluation, in that you have both history as well as clinical examination. Based upon the examination findings, you have various interpretations. So that the methods of breast palpation, you have the vertical stripes method, you have the horizontal stripes method, you have the dial clock method and all that, right? Then you move on to the clinical findings. Each individual component will give you a certain set of diagnosis. So what are the findings that you see in the nipple? What are the findings that you see in the skin over the lump? And what are the various findings that you will see in the axilla? So I've covered all the findings that are present on the nipple. We'll go with the skin over the lump, right? So when the skin over the lump findings are there, you can see an image like this, right? Now this is a classical image. I hope everybody knows it. This is the classical image of Piode orange. This is the classical image of Piode orange, right? Now this Piode orange is nothing but orange peel like skin. This is an orange peel like skin. Now this orange peel like skin or the Piode orange, it occurs because of subcutaneous edema. So this orange peel like appearance is a component that occurs because of subcutaneous edema. That is because of subcutaneous edema. Now this subcutaneous edema usually occurs. So what is the reason for this orange peel like skin? It is due to the obliteration. It is due to the obliteration of subcutaneous lymphatics. It is because of obliteration of the subcutaneous lymphatics. There is an obliteration of the subcutaneous lymphatics that will result in orange peel like skin. Now to get a grip of it, let's say we talk this as the representation of the epidermis. Let's say this is the epidermis of the skin. And let's say below the epidermis you have the dermis of the skin, right? Let's say this happens to be, this is the dermis of the skin, and below the dermis you have the subcutaneous fat. Below the dermis you have the subcutaneous fat. Now imagine that this is the lymphatic channel. This is the lymphatic channel which is going to drain the lymph from this particular subset of the skin, right? So this is the lymphatic channel. Now this is going to drain into a bigger channel, right? So just for the hypothetical understanding, I've given you the orientation of the skin, then you have the epidermis and the dermis, then the subcutaneous fat is there. Usually in the subcutaneous plane you have the lymphatic drainage that is present. Now due to some reason, let's say this lymphatic drainage is getting occluded. If this lymphatic drainage is getting occluded, what will happen? The lymph that was supposed to flow, from this region into the lymphatic duct is now getting blocked. So what will happen? All the lymph will start getting accumulated in this area of the skin. Now the skin is now filled with this edematous or the lymphatic fluid. So lymph is not able to go, the skin is getting congested. Now as the skin is now getting congested, what will happen? You now see the skin is going to become dilated. It will become edematous. So you will see this edematous skin because of the lymph which is not able to drain. Now this edematous skin that you can see, so it's the edematous skin where the lymph is not able to drain. This edematous skin will give you a classical Piode orange appearance. It will give you a classical orange peel like appearance. You see this edematous skin where it is now filled with this edematous fluid. It will appear like this. So this edematous skin, the skin become edematous, and then when you observe carefully, you see these pores are present, and this porous skin, they become quite evident. These are where the hair follicles are attached, so they become quite evident, and the skin becomes completely edematous, and this is what we call as orange peel-like appearance. Why is that? There is something which is obliterating the subcutaneous lymphatics from draining it, right? Now this could be a tumor, it could be a debris, or it could be an inflammatory cells. So that is why we say that POD orange is usually seen. So if you look at the entire representation, the POD orange can be seen in number one, it can be seen in breast cancer. It can be seen in breast cancer, or in inflammation you have rubercaloid tumor. Tumor is edema, again you will have orange peel-like appearance. So here it is seen in acute mastitis. It is seen in acute mastitis. Right, so it is seen in breast cancer as well as in acute mastitis. Now, very important thing is, whenever you have a patient of a breast cancer, and that patient of breast cancer develops POD orange, what is the staging? And this is usually your exam question in your competitive exams. Let it be your NEET, PG, INI, CT, FMG exam. Whenever they ask you a question in the exams, they'll be like this. So this is your T4B. So what is this T4A, T4B, what is T1, T2? We'll talk about it in breast cancer and its component. For now, you remember, if the involvement of the skin is present, it will directly become T4B. If the chest wall is involved, it is T4A. Okay? Now, how do you know there's involvement of the skin? POD orange indicates involvement of the skin in breast cancer. Okay? So don't worry. Just for the sake of understanding, if you want to have a quick recap, T1 is a size less than 2 centimeters, T2 is 2 to 5 centimeters, T3 is more than 5 centimeters. T4, any size involving the chest wall. Chest wall is made up of, we already discussed in our breast anatomy, it is made up of what? It is made of ribs, intercostal muscles, and the serratus anterior group of muscles. So any size involving the chest wall will become 4A, any size involving the skin will become 4B. If chest wall and skin both are involved, it will become T4C. And if there is inflammatory breast cancer, which is involving more than 1/3 of the breast, which is going to get inflammatory lesion and associated with malignancy, it is what we call as T4D. So here the patient is having a POD orange appearance, and presence of POD orange with association with breast cancer will directly upstage it to T4B. The best example is, let's say I have a patient with a 2 centimeter lump. A 2 centimeter breast lump classifies as T1 disease, correct? Now the same 2 centimeter breast lump with POD orange, if it comes, it will directly become T4B disease. A T1 is jumping to T4B just by having POD orange. So POD orange is as good as involvement of the skin in the breast cancer. Okay? So this is your orange peel-like appearance, or also called as POD orange. So I hope everybody is clear with this context. Okay? Another finding that you can see in this image, you can see there's a slight depression here, right? You see the skin is being drawn inwards. Now this indrawing of the skin, over a lump, over a breast lump, is what we call it as dimpling. This is what we call it as dimpling. So indrawing of the skin over a breast lump is what we call it as dimpling of the skin. Now dimpling basically tells you that it is because of involvement of Cooper's ligament. It is due to infiltration or involvement of the Cooper's ligament. We have already learned that Cooper's ligament anteriorly attaches to the skin, posteriorly attaches to pectoralis fascia, correct? So Cooper's ligament, if you look at the basic representation, if this is a representation of the breast, just for the sake of understanding, this is the nipple, and let's say this happens to be the pectoralis fascia, right? Now we have the Cooper's ligament, which are running in this particular fashion. Right, so this is the orientation of the Cooper's ligament. This is the orientation of the Cooper's ligament. Now let's say there is a lump that is developed here, that is arising from the duct, right? Now as the lump increases in size, it is going to infiltrate the Cooper's ligament. Now as the Cooper ligament is going to get infiltrated, it is now going to pull the Cooper's ligament towards the lump, right? Common thing, it will pull the Cooper's ligament towards the lump. Now, as the Cooper's ligament is being pulled towards the lump, you will see, because anterior is attached to the skin, posterior is attached to pectoralis fascia. You will now see the pectoralis fascia will be drawn inwards. At the same time, you see the skin is also drawn inwards, right? Because pectoralis fascia is deep inside, clinically I cannot see it. But clinically, what can I see? Clinically, I can see this indrawing of the skin, and this indrawing of the skin clinically is what we call it as dimpling. So dimpling is usually associated with the tumor infiltration of the Cooper's ligament, as simple as that. Okay? Now here is an interesting thing. Where else do you see presence of dimpling of the skin? So dimpling, one example that I've already given you, that it will be seen in breast cancer. First, it will be seen in carcinoma breast. Second, it will also be seen in a condition like chronic mastitis. It will be seen in a condition that is a chronic mastitis, right? Chronic inflammation heals by fibrosis, and the fibrosis of the Cooper's ligament will condense, and condensation of Cooper's ligament will draw the skin inwards. So another reason for dimpling is going to be your chronic mastitis. Now, when you look at the staging, as we told you that if there is PO the orange and the patient is having a breast cancer, the directly stage become T4B. The example that we took was a 2 centimeter lump is a T1 disease. A 2 centimeter lump with PO the orange will become T4B disease. Same, a 2 centimeter lump is T1. A 2 centimeter lump with dimpling, what will happen? If 2 centimeter lump with dimpling, what do you think is going to happen? Nothing, right? Remember, dimpling does not change the staging. It does not alter staging. So presence of dimpling in breast cancer. Presence of dimpling in breast cancer do not alter the staging, but then it does tell you that the underlying lesion could be a malignant lesion. That's the carry-home message with respect to dimpling. So we understood two important findings. One is the PO the orange, another one is the dimpling of the skin. Another one is the dimpling of the skin. Another one is the dimpling of the skin. Another finding that you can see, obviously it's quite evident in front of us. This is what we call it as the skin ulceration. This is skin ulceration over breast lump. Right? So there's a skin ulceration over the breast lump. So what are the reasons for the ulceration of the skin? Now the reason for ulceration of the skin can be in two conditions. One, it could be seen secondary to your phylloids tumor. It can be seen secondary to a phylloids tumor. Second, it can be seen secondary to breast cancer. Either it could be seen secondary to a phylloids tumor, or it could be seen secondary to a breast cancer, right? So in phylloids tumor, how does the ulceration occur? The reason for ulceration in a phylloids tumor, it is due to pressure induced necrosis. It is due to pressure induced necrosis. It is due to pressure induced necrosis. Okay? As the size of the lesion continues to increase, it exerts more pressure on the skin, overlying skin. Now as the size continues to increase, the pressure on the skin increases. As the pressure increases, the blood supply to that area of the skin decreases, resulting in hypoxia, and that hypoxia results in ischemic status, and that ischemic status results in ulceration, right? So in phylloids tumor, it is pressure induced necrosis that results in ulceration. In breast cancer, there's a direct infiltration. It occurs due to direct infiltration. It occurs due to direct infiltration of skin by the tumor cell. By the tumor cells. And that is why whenever you have a patient with breast cancer, and if there is a ulceration present, ulceration in breast cancer, ulceration in breast cancer directly classifies to be a T4B disease, right? It directly classifies to be a T4B disease, right? So ulceration of the breast cancer directly classifies it to be a T4B disease, as simple as that. Okay? So these are the important findings that you have in terms of lump skin over the breast lump. So there could be PO the orange, it could be presence of dimpling of the skin, and there could be associated there could be presence of associated ulceration of the skin, right? So these are the important components that you need to remember with respect to the clinical examination of the breast lump. Clear? Okay. Everybody is fine with this. Okay. Now, once you're done with the clinical examination, as I told you, it's a stepwise approach. In a stepwise approach, you had a patient who has come to you in the clinic, and now, or let's say in the OPD, where the patient is complaining about a lump in the breast. Now, as a lump in the breast, you did a clinical examination, you did a nice evaluation. Now you had certain findings which are pointing towards either a benign or a malignant disorder. Now, to conclude it further, we would send it for radiological investigation. So step 2, the step 2 in our assessment. The step 2 in our assessment is going to be a radiological assessment. So you're going to send it to these glorified photographers and to find out is there anything which is going to be relevant. Now when they enter into the radiology suite, it is like a buffet, right? The radiologist will ask the patient, what would you like to have? Would you like to have an ultrasound? Would you like to have an MRI? Would you like to have a mammography? And all and all and all. Okay? Now, there's always a correct consensus that what should be chosen for what patient, in what suspicion, which investigation is to be done. That clarity you should have. First thing. Second thing, whenever you go into the breast pathologies, there is no role of CT in diagnosis. CT chest, head and neck or thorax will be relevant when you're talking about staging of breast cancer once you prove the diagnosis is of breast cancer. As simple as that. Okay? Now in step 2, we are going to go ahead with radiological assessment. Now in the radiological assessment, we have the ultrasound, we have the mammogram as well as MRI. Okay? What are the current indications of ultrasound that you can perform? So currently the indication of ultrasound is any female of age less than 40 years with palpable breast lump. Any female of age less than 40 years with palpable breast lump, ultrasound becomes the first investigation. I'm not saying it is the investigation of choice. It becomes the first investigation, right? So the first investigation in this patient will become ultrasound, right? What are the other indications, right? So for all inflammatory breast lesion, it becomes the investigation of choice. For ultrasound is the investigation of choice for all inflammatory breast lesions. For all inflammatory breast lesion. Ultrasound is also considered to be as the investigation of choice. It is also considered to be as the investigation of choice for breast abscess. So I'm writing it separately. Breast abscess is also an inflammatory disorder, but just to get you an objective corrector, it is also the investigation of choice for breast abscess, which is also called as lactational mastitis. It is also known as lactational mastitis. It is also known as lactational mastitis, right? So what are the current indications of ultrasound that you have? The current indication of ultrasound is going to be any female of age less than 40 years with palpable breast lump, any patient who's having an inflammatory breast lesion, and all the patients who have breast abscess or lactational mastitis. It is going to be your investigation of choice. Hi Santosh sir, I'm just trying to match your writing, no, so that I keep up with medicine. I don't want people to say that medicine guys write well and surgery guys don't write well. Okay? I'm just trying to prove, that I can also write well. Right, guys. So, right. So this was the indication for ultrasound. What are the indications for mammography? Right. Now, the current indication for the mammography, it is going to be any female. It is going to be any female with age above 40 years with palpable breast lump. So any patient age above 40 years with palpable breast lump, the first investigation here is going to become mammography. The first investigation, it is going to become mammography. So any female age more than 40 years with palpable breast lump. So why are you doing ultrasound in age less than 40 and mammography in age above 40? In a simple context, it is something to do with the density of the breast. In younger females, the breast is of higher density. Now, because of that high density, when you do a mammography, the lesion, if present, cannot be depicted well. So the best modality to deal with that is going to be ultrasound. But as the age increases, the density of the breast decreases because it is replaced by fatty tissue. As the density decreases, it is easier for me to look with respect to mammography, right? Again, ultrasound is operator dependent, mammography is not operator dependent. So another reason why to choose mammography over that, right? So when it comes down to mammography, no, currently mammography is considered to as the investigation of choice for screening breast cancer, in general population, right? Everybody knows it. So in your exam, when they ask you a question, no, their line of questioning is, at what age should I start screening? Remember, it is after the 40th birthday of the patient. So this becomes your exam question. At what age would you like to start the screening for a general population for breast cancer? The answer is going to be after the age of 40 years. It is going to be after the age of 40 years, right? Now the radiation exposure that you have. The radiation exposure associated with mammography, it is going to be 0.1 gray units, or also called as 1 micro gray units, right? Either you say 0.1 gray units, or you can also call it as 1 micro gray units. So it's not a great radiation exposure, so hence it is a safer modality as well. So whenever you're doing a mammography, in the mammography, let's say this is the representation of the breast, right? There are two views that you can have on a mammography. So this is a representation of the breast. This is the nipple areola complex. Whenever we draw the breast, I told you we will always depict with a triangle, and that triangle indicates the axillary tail of Spencer, which tells you which is the lateral side, which is the medial side. So when doing a mammography, there are two ways of doing, two orientation in which to. One, you will direct your beams in this fashion. That is your craniocaudal view, right? So this is how one view of mapping. Here you can see the breast compressions. Another one is you put the machine in an oblique fashion. So you put the machine like this, it will give a craniocaudal view. But if you tilt the machine, right? If see mammography, you'll have two plates in which you will put the breast and you compress the breast and you take the image, right? If you put the plates like this, you'll get a craniocaudal view. But if I change the orientation, that means if this is the breast of the patient, and if I put the plates like this, is a craniocaudal. If I want to take a mediolateral oblique view, I will put the plates like this. Now you can see there is an oblique plates which are placed. So this time the beams are going to travel in this particular fashion. This is what we call as the mediolateral oblique view. This is what we call as the mediolateral. In an oblique fashion you have put it. This is an oblique view, right? So there are two views that you have. Number one, it is the craniocaudal view. This is your craniocaudal view. And this is your mediolateral. This is your mediolateral oblique view. This is your mediolateral oblique view, right? So there are two views that we have. We have two views that we have. One is going to be a craniocaudal view. Another one is going to be a mediolateral oblique view. Advantage of the cranial view is whenever I am using a cranial view, I can see the breast compression. So any disorder associated with the breast compression, so breast compression or breast scarring, that can be seen on this, right? Maximum amount of breast tissue. The maximum amount of breast tissue can be assessed by mediolateral oblique view. It can be assessed by mediolateral oblique view. Okay? Now, another interesting thing to know about the mammography is any patient who has undergone a mammography, remember, mammography, it increases the survival. It increases the survival by 30%. Now, how can a simple investigation or radiograph or a radiological instrument increases the life expectancy. It is very simple. Now, because you're using mammography as a screening tool, that means without having any symptoms, without having any palpable lesion, you're still looking for it. So the probability of finding it earlier is much more higher. Early diagnosis means early intervention, and early intervention means better prognosis. Better prognosis means longer lifespan. So hence it increases the survival by 30%, right? So these are the important aspects with respect to mammography. So currently mammography is the investigation of choice for screening as well as palpable breast lump in age above 40 years. Okay? Now, when would you like to do an MRI? So when you talk about the MRI, the current indication of MRI becomes the investigation of choice for screening breast cancer, in high risk population. It is the investigation of choice for screening breast cancer in a high risk population. Now, who are the patients who qualify it to be as high risk? So I can say patient with BRCA gene mutation positive, patients who have first degree family history of breast cancer, right? So whenever you have a patients who are having these components, the age at which you would like to start screening is after 25th birthday. So age of screening will be after 25 years. If you have a patient with high risk population, for that MRI becomes the investigation of choice. Another interesting thing, MRI is also the investigation of choice for breast implant associated complication. It is the investigation of choice for the breast implant associated complications. As simple as that. See? So we talk about intracapsular ruptures, extracapsular ruptures, anything associated with breast implants, you will resort to MRI. So now we have a clear-cut idea that when are we going to use ultrasound, when are we going to advise for mammography, and when are we going to advise for MRI. See? Now, there are certain things that you should be able to interpret when you get these findings. So I'm going to give it to you in a very component way. So the first image that I would like to depict here is going to be an ultrasound. This is an ultrasound of axillary lymph node. This is an ultrasound of the axillary lymph node, right? So when you look at this, what is the first thing I see? The first thing I see that all the borders are uniform. So there is a uniform margin, right? The first thing. Second thing, whatever is inside this, they are of equal density. There is no change in density. I'm not seeing some areas which are more black, some areas which are more white. No, it's all uniform. So there is uniform. There is homogeneous density. There's homogeneous lesion. The third thing I'll see, I will measure the length and the width. They are almost same. So it is spherical. If you have a presentation like this, I can say it is a benign lesion. So how do you know it is a benign lesion on a radiograph? Number one, there will be a uniform margin, or I can say it will have a regular margin. It is not irregular, it will have a regular margin. Second, it will be homogeneous. It will be homogeneous. Here the length and width of the dimension is almost equal, right? It is uniform, regular margin, homogeneous. The length as well as the width remains absolutely same, right? Now you go to the second image. Same, you have the ultrasound of the axillary lymph node. This is the ultrasound of the axillary lymph node. So when you compare with the first image that we have learned, that whenever you have a lesion or a node which is going to have a uniform margin, they all, the density is homogeneous, the length and the width is same, they're the most spherical in nature, I'm pretty sure it is benign lesion. But when you come across here, if I map it across, see, this is how it is looking. So the first thing I know, it is not a regular margin, it is having an irregular margin. Next, you can see there are certain areas which are of different density. You can see there are different tissue densities which are present. So some areas there are, this all black is there, some white is there, some white is here, more black is there. So there is heterogeneous. Then you see the margins are irregular. So with the same context, I can just add the terminologies here. It is going to have an irregular, or also called as the speculated margin. Now this speculated margin is also called as a comet tail margin. There are other names which are given. It is going to have a heterogeneous, so different densities is there. And more importantly, when you look at this entire context, if I just show you the entire lesion per se, right, you can see this is the entire lesion that you're looking at. So I can say if this is the length of the lesion and this is the width of the lesion, I can say length is always more when compared to width. So if it is longer than wider, that is taller than wider, that is a term used. So here the length of this lesion will be more when compared to width. So it is taller than wider. If the word used is taller than wider, all these goes in favor of malignant lesions. That is irregular, speculated margin, heterogeneous, length more than width. All this goes in favor of what? They go in favor of malignant lesion per se. See? Next you come down to mammography, right? So in the mammography, I have the first image of a mammograph. Here you can see there is some calcification there. Now the calcification is quite big. So I would say this is an image of macrocalcification. It is an image of a macrocalcification. Now whenever we say macrocalcification, there has to be a size demarcation to call it as macro. If the size of the calcification is more than 0.5 millimeters, this is what we call it as macrocalcification. So the size of a calcification, if it is more than 0.5 millimeters, it will be called as your macrocalcification. Now when you look at the appearance of this calcification, it looks like a popcorn. So characteristic appearance that you can see here, it is what we call it as the popcorn calcification. This is what we call it as the popcorn calcification. This is what we call it as the popcorn calcification, right? So when the term comes as popcorn calcification, we should know what are the other forms of popcorn calcification we can see. So when you see a popcorn calcification in a mammography, now these are your NEET PG, INI, CT, FMG questions. That is your competitive exam. So popcorn calcification on a mammography is seen a condition which is called as the fibroadenoma of the breast. It is called as the fibroadenoma of the breast. That is your mammography. If you see a popcorn calcification on a chest X-ray, then the condition is called as the pulmonary hamartoma. Then it is going to be pulmonary hamartoma. That is on chest X-ray. Now, if you see a popcorn calcification on the MRI head, then the answer here is going to be cavernous hemangioma. It is going to be the cavernous hemangioma. Now, on the other hand, if you see the popcorn, not calcification, the popcorn cells, right? So if you see a popcorn cells, these are seen in lymphocyte predominant Hodgkin's lymphoma. This is a type of Reed-Sternberg cells, right? In a Hodgkin's lymphoma, there are a type of Reed-Sternberg cells. So various popcorn calcifications that you are expected to know. So popcorn calcification mammography is seen in fibroadenoma, chest X-rays pulmonary hematoma, MRI is going to be cavernous hemangioma, popcorn type cells are seen in lymphocyte predominant Hodgkin's lymphoma. So there are various aspects that you should be aware of. Okay? Now if you see a mammography and image something like this, so how do you decode this? The first thing, I can see that the margins are not regular, so you have the speculated margins. So they are irregular margins. So there are speculated margins are present. Okay? So first, this is a speculated margin. Look at, this is the normal density of the breast, and look at the density of the lesion. It is more, so it is over or hyperdense is there. Okay. Second, you can see the certain areas, if you look within the lesion, this area is less denser, this is more denser, this is less denser. So there is heterogeneity is there, right? There is heterogeneity is there. If I remove these circles, you'll be able to see again. Right. So on a mammograph, you find these. What are these? You have the irregular margin. You have the irregular margin, which is also called as a speculated margin or also called as a comet tail appearance, right? It is also associated. It is heterogeneous. And this is of high density. Now, I'm not going to say that it is going to be a benign or a malignant lesion, but as a radiologist, whenever they report, no, because seeing a benign or malignancy is actually a cytological diagnosis. Here we will use a classification that is called as breast imaging reporting and data system, that is BIRADS, and category 5, that is highly suggestive of malignancy. So don't worry about it. We'll talk about what is BIRADS stands for, that is breast imaging reporting and data system. So we'll talk about what is BIRADS and how it has been implicated. For now, it is remembered, if you have such a margin, it is going to be BIRADS 5. Another mammographic image that you can get here. I'm just going to give you the finding here. Again, you can see hyperdense, speculated margin, irregular on that. But very carefully, if you see these areas. So the calcification is there. You can see these calcification. These are what we call it as micro. You can see this circle, you'll see pretty well. These are what we call it as micro calcifications, right? So if there's a cluster of micro calcification, if there is a cluster of micro calcification, as I told you, the criteria to call it as micro will be less than 0.5 millimeters in size of calcification, because more than 0.5 is going to be macro calcification. So presence of less than 0.5 millimeters in size of micro calcification, it points towards malignancy, right? So again, here also, when your radiologist is going to report, they will report with BIRADS category 5. They'll also give you BIRADS 5. In fact, presence of microcalcification probably indicate this is the lobular carcinoma. This indicates presence of lobular carcinoma, right? This is your lobular carcinoma. Okay? So these are the various radiographic images that you should be aware of when you're talking about the breast pathologies. Okay? There are a lot of it. As we continue to move into our lecture, as we come across various pathologies, we'll show you the radiographs of that particular pathologies as we move forward. Okay? Now, so we had a patient who came down to us, we did a clinical examination, we did a radiological assessment, these were the findings. Based upon the findings, now we have suspicion, either thinking about benign or malignant. In that context, you would do a tiebreaker with a cytology. Now, in a cytological assessment, you have two components. One is your FNSC, another one is TrueCut. FNSC stands for fine needle aspiration cytology, and TrueCut biopsy is a through and through biopsy that is going to be present. Just for our sake of understanding, I have simplified this. The green one is what we call it as the normal cell. The orange one is what we have the tumor or the neoplasia, and this is your basement membrane. So normally whenever we talk about receptors, the receptor status is usually embedded in the basement membrane, right? So ER, PR, HER2 neogene status, everything will be embedded in your basement membrane per se, right? Now, Arun Lodhi, okay. But if you are, this is not a patho class, no? This is a surgery class. Okay? Okay, if you're good with stains, see, I'm a surgeon, I hardly know any stains. We have our good pathologists to look into stains and give me a reporting. I am a person who looks for diagnosis, management, treatment, and that too a surgical one. ठीक है? तो सर्जरी वालों में इतना दिमाग नहीं होता ना बेटा कि बैठ के पढ़ लो कि कौन सा स्टेन है क्या है and all that, right? So we're good with operating. Let the stains and the markers, yes, I would love to take up with, on a different scale, but stains and all is not my cup of tea. Okay? Chalo. So how do you compare the FNSE with a true cut biopsy? When you talk about FNSE, the size of the needle that I'm going to use is going to be 22 to 26 gauge needle. Single best answer is going to be a 23 gauge needle, which is more specific. Whereas for a true cut, I'll be using a 14 gauge needle. Now you have estrogen receptor, the progesterone receptor. ER stands for estrogen receptor. ER stands for estrogen receptor. PR stands for progesterone receptor. And HER2 neogene status is there, right? In an FNSE, I cannot assess the HER2 neogene ER PR status because I cannot assess the basement membrane. When it comes down to true cut biopsy, because I'll be able to assess the basement membrane, I'll be able to assess all three of them, the status of ER, PR as well as HER2 neogene status. Now, how do you know particular tumor is in situ or invasive? It is by assessing the basement membrane. If the integrity of the basement membrane is maintained, that means the tumor does not infiltrate. This is in situ. If the integrity of the basement membrane is lost, if the tumor infiltrates into the basement membrane, it becomes invasive. Again, as I told you, I will not be able to assess on FNSE because I cannot assess basement membrane, whereas in TrueCut I can. The only advantage that you see with an FNSE, it is going to be a very little pain, whereas in TrueCut the pain increases. FNSE does not have any scar. TrueCut will leave a scar behind. But if they ask you a question, which is going to be the investigation of choice for breast cancer, the answer is going to be TrueCut biopsy, not FNSE. So when would you like to go ahead and decide that you want to do an FNSE or a TrueCut? Clinically and radiologically, if you're suspecting the patient is having benign disease, you go with FNSE. Clinically and radiologically, you're suspecting the patient to have a malignant lesion, then you go ahead with TrueCut biopsy. So that is how you differentiate whether to go with FNSE or to go with TrueCut biopsy. So whenever you're doing an FNSE, on histopathology, there are two important slides that you will see in our pathology that there. The first slide that you can see, this all this branching, it's like a leaf-like arrangement. So this is what we call it as the leaf-like arrangement. This is the leaf-like arrangement of tumor cells. This is the leaf-like arrangement of the tumor cells. And this leaf-like arrangement of tumor cells is what we see in phylloids tumor. Another finding that you see, this is as if, the people who are, so there are these native Indians are there, they used to stand in line, and then they used to, whenever the war used to be there, they used to form into a standard line and then stand. And this is what we call it as Indian file appearance. So when you look at the slide here, you see all these stains, they appear to be in this particular line. So they are standing in these lines. So hence it is called as the Indian file appearance. This is what we call it as the Indian file appearance. Now this Indian file appearance is seen in lobular carcinoma. This is seen in the lobular carcinoma of the breast. Okay. So we had the phylloids as well as the lobular carcinoma. There are two important histopathological slides that you have, right? So if you look at the entire component, we had a 3-step process that we have. The step 1 that we had, it was of clinical evaluation. After clinical evaluation, we went to step 2. The step 2 was a radiological assessment. The step 2 is our radiological assessment. Then you have step 3. So in a step 3, you have the cytology. Right? if you combine all these 3 steps together, step 1, step 2 and step 3, all these 3 steps put together is what we call it as a triple assessment. This is what we call it as the triple assessment. That means from the point the patient arrived to you in the OPD till you got a cytology to gain a diagnosis or to confirm a diagnosis, this entire process is what we call it as triple assessment. Now currently, if you follow triple assessment protocol, what is the sensitivity? Now the sensitivity of the triple assessment that you have is 99.9%. The sensitivity of the triple assessment is going to be a 99.9%. That means if you follow a triple assessment protocol, it is very unlikely that you're going to miss on diagnosis. It is very unlikely you're going to miss on diagnosis. The sensitivity is going to be 99.9%, right? So this is in the assessment of a breast lump from the beginning to the end. It is from the beginning to the end. Okay? So this is all that you should know in the context of breast lump assessment, right? So that is it for today, guys. Thank you so much for joining in the BLS. If you have any questions, any queries, you can just ask right now. And if you forget now, or you don't remember to ask now, you know where to reach out. We have the Telegram and Instagram channel that is called as the Surgery Guy. This you will find it on my name. It is the Surgery Guy. This is Dr. Sandeep Seeram Reddy. Right. So this is all in all that we had it for today. So we have completed the first leg of the breast disorders, the breast chapter. From tomorrow, we'll start with the benign disorders. There will be 2 lectures on benign disorders. The next week is completely dedicated for breast cancer, management, surgery, and reconstructions. Okay? Helix, we are going to start the Furray series. I think they have already given you the schedule. The medicine is going on right now. I think the surgery is going to be somewhere in the mid of Feb or end of Feb. I just need to check. But yes, we are doing the Furray. We will complete the entire surgery on the Furray as well. Okay? Chalo. Thank you so much, guys. We'll see you again tomorrow. Tomorrow the class will be from 9 to 10. Okay? Kal 9 se 10 rakhenge. Okay? Thank you so much. See you guys. Have fun. Bye bye.